rectangular. This is a rectangular box-like structure. There's an equal to sign. So as I've already explained, from the sagittal section of the spine, we rotate the probe 90 degree, identify the junction of cervical spine, rotate 90 degree, you get the transventricular plane. Then you go a little more backwards, caudally, you get the transthalamic plane, then a little more backwards, you get the transcerebellar plane. Yes, the most important plane, that is a transventricular plane. This is the most cephalid of the three planes. So this one plane gives a clue to many things. This one plane, 4 or 5 structures, and we get to know many things. Number one, integrity. Whether the skull is intact or not. We have to see at the integrity of the skull. The whole skull is intact or not, or whether there is a defect in the skull. If there is a defect, we will suspect there will be a herniation of any brain tissue. We can suspect encephalocele. Encephaloceles are also easily detectable in the first trimester, unless and until it is very small. You may miss it. Otherwise, it is easily detectable, because if you look carefully at the integrity of the skull, you will not miss it. Then bone density. How is a bone density? We have to look at the bone density. How will it look? That is, it signifies a mineralization of the bone. How good is a mineralization? If the mineralization is good, then because of the reverberation artifacts, you won't be able to see the near field. This is a near field. You won't be able to see the near field carefully. If the bone mineralization is poor, if there is a poor bone mineralization, then there won't be any reverberation artifact, and this field will become very beautifully visualized, which we don't want.
I'm unable to see.
This happens in osteogenesis imperfecta. So looking at the bone density, again, if this field is seen very beautifully, that means we are dealing with a case of osteogenesis imperfecta. Then FARCs, the midline FARCs, the FARCs which is interrupted by CSP. Which is the FARCs? This is the FARCs. This is the midline structure. This midline structure, this midline structure, this midline structure. This is the FARC cerebri. It divides the cerebrum into 2 cerebral hemispheres. This FARCs is interrupted by CSP. This is known as the cavum septum pellucidum, or the CSP, another very important structure. So we have to look carefully at the FARCs. Then occipital or posterior horn of the lower lateral ventricle. Which is the occipital horn? This is our ventricle, lateral ventricle. This is the occipital horn. This is the occipital horn. This is the frontal horn. Occipital horn, frontal horn. Then we have to see at the occipital horn. Then look at the frontal horns. This is the frontal horns of both lateral ventricles. So very easy. We will see whether the skull is intact or not. We will see the bone density, whether there is a good, whether there is a poor visualization of near field or not. Then we'll look at the midline FARCs. Then we'll look at the lateral ventricle, the occipital horn of the lateral ventricle. And then we will see at the frontal horns of both the lateral ventricle. This was about the transventricular plane. These 5 structures, if there is abnormality in any of the structure, if you don't find the normalcy in this plane, then easily pick up abnormalities. Then another very important thing in the transventricular plane, that is how to measure the arteria of the lateral ventricles. The measurement technique is very important. So this there should be a symmetrical axial view of the opposite. These both hemispheres should be symmetrically visible. Then where should the atrium be measured? The atrium should be measured at the level of glomus of choroid plexus, opposite the parieto-occipital sulcus. So this is the occipital horn. This is the choroid plexus. This is the choroid plexus, and this is the glomus of the choroid plexus. And here also you can see one structure, that is a parieto-occipital sulcus. This is the parieto-occipital sulcus. So where do we measure the atrium? We measure at this level, at the glomus of the choroid plexus, opposite the parieto-occipital sulcus. This is a very important landmark. This has to, because we get many cases referred to as ventriculomegaly, but when we see it comes out to be normal, just because of the error in the measurement of the area of the lateral ventricle. So where should the calipers be placed? The placement of calipers is also important, as we do it in NT scan. So caliper should be placed touching the inner edges of the ventricular wall. So This is the inner edge of the ventricular wall. It is widest part, and it should be aligned perpendicular to the long axis of the ventricle. So if this is the long axis of the ventricle, it should be aligned perpendicular to it. So this is how we measure the atria of the lateral ventricle. Glomus of choroid plexus, opposite the parieto occipital sulcus, and inner edges. This is what we have to remember. Then at this measurement of atria of the lateral ventricles, what is, as I said, they should be at the level of parieto occipital sulcus, at the level of glomus of choroid plexus. So what is a normal measurement? The normal measurement is 10 millimeter. If it comes out to be more than 10 millimeter, then we have to refer the patient. So the rule of 10 we have to apply, like Cisterna Magna also 10, and the lateral ventricle, the occipital horn of lateral ventricle also 10 millimeter. Then one more important thing, besides seeing the lateral ventricle at the far field, this was whatever I have said till now is of far lateral ventricle. The far lateral ventricle is measured in every mid-trimester anomaly scan. But what about the near one? If we don't see the near one, then we may miss the unilateral ventricular vagality. So near lateral ventricle has to be eyeballed. We need not measure it, but it has to be eyeballed. It should be measured only if suspected to be dilated. Near ventricle is measured in symmetric axial section, means both the ventricles you should see in one plane. Then near lateral ventricle is obscured by the reverberation artifact. So how do we image? Imaging is through the near lambdoid suture. It reveals a near lateral ventricle. Midline 35 to 45 degree to horizontal. Means if you take the horizontal plane, then just tilt it little bit to try to get the oblique plane. Oblique plane, then we can see the near ventricle. So this is at this level, you see, this is an axial section, symmetrical axial section. At this level, we can measure even this ventricle. This near ventricle also can be measured. This is one video which I have taken. So just tilt the probe little bit oblique. We get little bit open, you can get the near ventricle. See, we can see this one. And at least eyeballing can be done. We need not measure it in all cases, but eyeballing has to be done in this case. Now come to the transthalamic plane. The transthalamic plane, what do we see? Again, we see the falx, the midline falx. This is as important as is in all the planes. Then the CSP, again an important structure, cavum septum pellucidum. Then both thalami in opposition and separated by the falx, and the hippocampal gyri and the lateral sulcus. This is the Sylvian fissure, is a lateral sulcus. Why is the transthalamic plane important? This plane is important because we take the biometry in this plane. We can even take the biometry in the transventricular plane, but it can be taken in both the planes, both transventricular also and transthalamic also. So what do you take? You take the BPD and the head circumference. How is the BPD taken? The BPD is taken from outer to inner, and you can directly take the head circumference, or you can take the occipitofrontal diameter also, that is from one end, this end, to the other end. So cranial biometry can be taken in transventricular plane or transthalamic plane. The angle of insonation is 90 degrees to the midline equus. There should be a symmetric hemisphere should be seen, and what has to be seen is the falx with the CSP and the thalamus, and the cerebellum should not be visualized. This is very important. The cerebellum should not be visualized. Otherwise, there will be an error in measurement of in taking the biometry. Then, what is the importance of the biparietal diameter and the occipitofrontal diameter? It is a cephalic index. Besides monitoring the growth, we also look at the cephalic index. What is cephalic index? Cephalic index is a biparietal diameter divided by the occipitofrontal diameter multiplied by 100. The normal value is 75 to 85. If it is less than 75, this is a dolichocephaly. If it is more than 85, it is brachycephaly. This dolichocephalic head, if the baby is in breech presentation, most of the cases when the baby is in breech presentation, we may get a dolichocephalic head. So that does not mean that it is an abnormal baby. So we can use the standard reference charts, and if the head circumference is outside the normal range, then we need to refer it to the to higher centers. Like this can be taken from the GE machine itself, or we have Fetal Medicine Foundation charts also there. We can compare it with and see whether it comes under below fifth centile or it is more. Now come to the cerebellar plane, another very, very important plane. So what has to be seen? We look at the cerebellum. This is the ensure the complete visualization of cerebellum. The cerebellum, although this image is not so good, but the next image will be seeing it. So we see the complete visualization of the cerebellum. We ensure the anatomical landmarks, and steep angulation should be avoided. So what has to be seen in this plane? Again, the frontal horns. We see the frontal horns of the lateral ventricle. We see the CSP. We also look at the FARCs. All this not written here, but FARCs also has to be seen over here. Then thalamus. Then cerebellum. What is the cerebellum? The cerebellum is a two dumbbell-shaped structure. It's a two dumbbell-shaped structure. This separated by the echogenic vermis. There's a vermis over here. Two dumbbell-shaped structures separated by the echogenic vermis. This after that, we see this is the Cisterna Magna. This is the Cisterna Magna, and this is the nuchal fold thickness. Although in ISIOG slides, they haven't mentioned about nuchal fold thickness, but I have added it because we routinely measure the nuchal fold thickness in the transcerebellar plane. Why do we measure nuchal fold thickness? Because it is a soft marker for trisomy 21. So when we do a mid-trimester anomaly scan, this acts as a soft marker. If this is more than 6 millimeter, the nuchal fold thickness is more than 6 millimeter, then it comes under a high risk group. Also, in case of fetal infections, if there's a fetal infections, particularly toxoplasma and CMV, then also the nuchal fold thickness may increase. This may increase. So again, I repeat, what do we see? We see the frontal horns, we see the thalamus, CSP, we look at the thalamus, we look at the cerebellum. This shape of cerebellum, we measure the cerebellum from outer edge to outer edge of the cerebellum. Then we look at the Cisterna Magna. How do we measure the Cisterna Magna? Cisterna Magna is from the outer border of the vermis to the inner border of the occipital bone. Outer to inner, outer to inner. And here, nuchal fold, how do we measure the nuchal fold? From outer border of the occipital bone to the outer layer of the skin. Outer to outer, the normal value of nuchal fold is 6, and the Cisterna Magna is between 2 to 10 millimeter, and 2 to 10 millimeter. Then come to the transcerebellar plane, transcerebellar diameter. This is a maximum diameter in the correct plane. This is from outer to outer. Why do we measure this transcerebellar diameter? Why is it important to measure? First of all, this diameter, it corresponds with the gestational age up to 22 weeks. So even if there is some discrepancy in the biometry, we can see at the transcerebellar diameter, and as is the gestational age. And if you get, if the TCD is less than 5th centile, then there's then the baby may have cerebellar hypoplasia. So a detailed investigation is needed, detailed scanning is needed in such cases. Then to Cisterna Magna. What is Cisterna Magna? How do we measure? Outer edge of the vermis. This is the outer edge of the vermis to the inner edge of the occipital bone. Outer edge of the vermis to the inner edge of the occipital bone. The normal range is between 2 to 10 millimeter. So when do we refer? We refer when the TCD is less than 5th centile for the period of gestation. Cisterna Magna is more than 10 millimeter. This space is more than 10 millimeter, and the cerebellar hemisphere appears separated. You don't get this connection. This seems to be connected by the echogenic vermis. If you don't see this connection, if this appears to be separated, then also some problem may be there. So this is one video which shows 3 planes in one go. So this here we get the transventricular plane. You see, this is the transthalamic plane, and here now we get the transcerebellar plane. This is the transcerebellar plane. So you can get all the 3 planes in one go. All the 3 planes in one go. I repeat. This is the this is the CSP, this is the lateral ventricle, this is the thalamic, then this is the transthalamic plane. Then again, I'm going caudally and I'm looking at the transcerebellar plane. Transcerebellar plane. So what are the ISO guidelines for fetal neurosonogram? In a low-risk pregnancy around mid-gestation, if the transventricular plane and the transcerebellar plane are satisfactorily obtained, the head measurements, the head circumference in particular, are within normal limits for the gestational age, the atrial width is less than 10 millimeter, and the cisterna magna width is between 2 to 10 millimeter, many cerebral malformations are excluded. The risk of a CNS anomaly is exceedingly low, and further examinations are not indicated. So the rule of 10 we can easily remember by the rule of 10. So what are the common abnormalities that can be excluded from these three planes? So the most easiest of abnormality, there's an always detectable anomaly, that is anencephaly, which is detected at the first trimester. In this figure, it is easily diagnosed, like one can easily diagnose, but at times it so happens that a patient comes with the first trimester scan done, everything normal. She comes to us at 18 to 19 weeks and we find anencephaly. Once again, it had happened, the patient had done the first trimester scan. She does a triple marker test. She gets a increased risk of neural tube defects. And when she comes to us at 18 to 19 weeks, we find an anencephaly. So besides taking the CRL measurement, this plane is important for at least not missing an anencephaly. Looking at this again, I have put the slide so that everyone can see. Looking at this plane is so important. Taking this biometry is so important, at least for not missing an anencephaly plane. So, like in this case, this baby. Suppose I'm having a rush in the clinic. I'm in a hurry. And I don't take the BPD plane. I take only the CRL. Then this anencephaly baby, I may miss. And then she comes again at the TIFA scan and to be diagnosed as an anencephaly. So I repeat, taking this plane is very, very important. Besides taking CRL, taking the biparietal plane becomes very, very important. Again, always detectable anomaly, always detectable anomaly, and very easily diagnosed anomaly, that is a holoprosencephaly. Holoprosencephaly, what is holoprosencephaly? The midline falx is absent in this case. There is no separation between the cerebral hemispheres. There is a continuity between the two ventricles, and it forms a monoventricle. This forms a monoventricle. There is no falx here. There are three types of holoprosencephaly, but the most common the most severe is the lobar, and the lobar is very easily detectable in the first trimester. So this is the lobar holoprosencephaly. Usually holoprosencephaly comes with many associated anomalies. Isolated holoprosencephaly is rare, and this is associated with trisomy 21. Like if the baby has a holoprosencephaly, we can have a strong suspicion of trisomy 13. So refer if midline falx is not visualized and the ventricles are fused. I have put this slide so that we can compare between these two. This is a normal plane, and you see this is a lobar holoprosencephaly. So very easily diagnosed. We don't find the falx. We don't see the choroid plexus filled ventricles. So we see a monoventricle here. So this is not a miss anomaly in the first trimester, holoprosencephaly. Then come to encephalocele. So as I had said about the integrity of the skull bone is important. Any defect in the integrity of the skull, as in this case, then you can suspect encephalocele. There is a cranial bone defect with herniated fluid filled or brain filled cyst. This is a brain filled cyst. So it can occur anywhere. It varies in size. This is most commonly occipital, as is seen in this case. It can be parietal or frontal. So it can be meningocele or a meningoencephalocele. So this is a encephalocele. So looking at the skull bone integrity becomes so important to diagnose encephalocele. Here's another image which shows another occipital encephalocele over here. So there are another septated cystic lesions when we look at the biparietal plane or look through the neck. So there will be a cystic hygroma. So we can looking at the BPD plane again, it becomes so important. So now come to the cranial vault and the lemon sign of the open neural defect. Like as I had said in this, again I have put this slide, this IT slide. That is this I said brainstem. This is the IT. This is Cisterna Magna. This is a NT. So IT. So there is a leakage of when there is a leakage of CSF, it pushes the IT downwards. There is obliteration of the IT. So as there occurs leakage of the cerebrospinal fluid, there occurs scalloping of the frontal bones. This is a frontal bones. So there occurs scalloping of the frontal bones, and this becomes lemon shape. You see, this is a lemon. This is the shape of the lemon. So there occurs scalloping of the frontal bones. So lemon sign. And when we move downwards, we find a big open neural tube defect. So lemon sign is a sign of open neural defect. So again, looking at the BPD plane becomes so important for us. Other head shapes, like as I had said about dolichocephalic head, whether cephalic index is less than 75, dolichocephalic head we can see normally in breech presentation, and strawberry shaped skull. This is a strawberry shaped skull. This is seen in case of trisomy 18. This is a clover leaf shaped head. This is seen in craniosynostosis and skeletal dysplasia. This is a brachycephaly. Then, as I've already explained regarding this is a poor, if there is a poor mineralization, you see here, we can see this near field is visualized, which is not good. This means that there is a defect in the mineralization of the bone. Here we can't see the we can't see the near field. That means there's a good mineralization, that is a good sign. So we are not supposed to see this near field. So if we are able to see this near field nicely, that means we are dealing with some mineralization disorder. It may be osteogenesis imperfecta. Then come to transthalamic and transventicular planes. I have already discussed about how to measure the lateral ventricles. Achha, one question: why do we measure the lateral ventricles over here only? Why don't we measure the lateral ventricles of frontal horn? We measure the lateral ventricles in the occipital horn because it's the first one to dilate. The ventriculomegaly starts in the occipital horn of the lateral ventricle. So again, we see with the level of glomus of the choroid plexus at the parieto-occipital sulcus, inner perpendicular to the long axis of the ventricle. So here it is 10.7. It means I'm dealing with a ventriculomegaly case. So here it is 16.7. So here, in addition to the dilation of the occipital horn, the frontal horns are also dilated. So again, the atrium of the lateral ventricle, if it is more than 10, then the patient has to be referred. Little theory regarding ventriculomegaly, as it is a very common scenario in our setting. So it is subdivided into mild, it is 10 to 12 millimeter, moderate, 13 to 15 millimeter, severe, it is more than 15 millimeter types. It is associated with many chromosomal defects, mainly trisomy 21, 18, 13. And when we find a ventriculomegaly, a detailed neurosonography is warranted. A detailed neurosonography has to be done. We have to offer the patient invasive testing like amniocentesis has to be offered for karyotype microarray and amniotic fluid PCR for detecting the infections, particularly toxoplasma and CMV. We can also go for maternal torch test for detecting fetal infections. One thing I have deliberately put because it can be an evolving abnormality. By evolving, because I have done the TIFA scan, I find everything normal, but again she comes to me at 32 to 34 weeks, I find a ventriculomegaly. Is it I have missed something? No. It so happens that at times this evolves. This evolving abnormalities becomes a nightmare at times because particularly the heart and the brain abnormalities, everything will be fine in the TIFA scan. But when they come at the time of growth scan, you'll find a new abnormality. So what has been taught to us, it has been taught us, our mentors have taught us that treat every scan as an anomaly scan. So whenever the patient comes to you, you have to see all the anomaly. All the anatomy has to be seen. So even in growth scans, we are supposed to see the anatomy of the patient, particularly heart, brain, everything has to be seen. Just it doesn't take much time. It takes another 5 to 10 minutes extra to just look over all those things. So an important structure that is a CSP. There's a cavum septum pellucidum. It is a rectangular box-shaped structure. If you get this good CSP, means you should be assured that the corpus callosum is good. So normal CSP on axial view, then normal corpus callosum in mid-sagittal. So if I get this plane, I need not go into this plane because I am reassured that my corpus callosum is fine. If I'm getting a good CSP, I need not go further. But if my CSP is not looking good, it's not looking healthy, then I have to go for another. I have to look at the mid-sagittal plane and look at whether corpus callosum is good or not. It measures normal or not, whether the vermis looks good or not. We have to see. So this plane becomes so important. This is an indirect measurement. The CSP is an indirect assessment of the corpus callosum. In agenesis of corpus callosum, you won't find this good CSP. So what happens in agenesis of corpus callosum? This is a normal plane. We see a good CSP over here. But what happens here in this plane? I don't see here any CSP over here. There's a single line. There's no CSP over here. In addition, the ventricle also appears abnormal. How does it appear abnormal? The frontal horns are pinched up. The frontal horns are pinched up and there is a teardrop shape. The lateral ventricle appears like a teardrop. This is known as colpocephaly. What is known as? This is known as colpocephaly. So absence of CSP or a defective CSP with colpocephaly, it also signifies agenesis of corpus callosum. Agenesis of corpus callosum. In yes, when should we see CSP? CSP is seen between 18 to 37 weeks of gestation. So if a patient comes to me at 17 weeks, then and I don't find a good CSP, that does not mean that there will be a agenesis of corpus callosum. I have to wait. I have to call the patient again at 19 weeks and look whether the CSP is good or not. Even the CSP is not good, then I can go for a mid-sagittal scan and see whether the corpus callosum is good or not. So between 18 to 37 weeks, a normal CSP is seen. Now come to transcerebellar plane anomalies. So we went through the lemon sign of the open spina bifida. Now the same pathogenesis, leakage of the cerebrospinal fluid, there's scalloping of the frontal bones, and this presses the cerebellum. The cerebellum presses and the cerebellum becomes banana shaped. The cerebellum becomes banana-like shape. So the three signs, like obliteration of IT, lemon sign, banana shaped cerebellum, they all are signs of open spina bifida. So if there is an open spina bifida, you will find an open neural tube defect will show its presence even in the head and brain planes. So what is this? This is a mega cisterna magna. When do we call it as mega cisterna magna? When the cisterna magna measurement is more than 10 millimeters. So we can see this one. This is 11.4. That means this is a mega cisterna magna. So if I find a mega cisterna magna, again I have to go for a detailed investigation. I have to go for a neurosonography. So again, this is a normal plane. This is a normal plane. This is, I see the cerebellum, a good cerebellum, vermis, cisterna magna, nuchal fold. But here what happens? This plane appears normal, but this is dilated. This is dilated. This is 11. So I'm dealing with a mega cisterna magna. In mega cisterna magna, the vermis is usually normal. The vermis is normal. The vermis is normal. But whenever you find this, neurosonography, a transvaginal scan has to be done to look at the mid-sagittal plane. Another abnormality of posterior fossa, that is a Dandy-Walker malformation. What is this Dandy-Walker malformation? That there is a communication between the fourth ventricle. So when I take the transcerebellar plane and I move little more caudally down, then I find the fourth ventricle. In Dandy-Walker malformation, what happens? There is a communication between the fourth ventricle and the cisterna. You see, this one. I don't find any vermis over here. And if you slide your probe little more downwards, you will find there is a communication between the fourth ventricle and the cisterna magna. So there occurs a cystic dilatation of the fourth ventricle. It fills the posterior fossa, extends into cisterna magna. And in this case, the vermis is usually hypoplastic or absent, which has to be confirmed, by a mid-sagittal plane. So another big image showing the Dandy Walker malformation. You see there's a hypoplastic cerebellum also in this case. Vermis is, appears to be small. There is dilatation of the cisterna magna. So if we slide that down, we can find the communication between the fourth ventricle and the cisterna magna. So this is by taking at this 3 planes, you can find the cystic hygroma, very easily detectable one. Is a septated cystic hygroma with hydropes. So what are the key features? The 3 planes. Our mind should know all these 3 planes. That is, there's a transventricular plane. We see at the skull, at the falx, the CSP, the lateral ventricle. What all can be diagnosed? Anencephaly, encephalocele, all lobar holoprosencephaly, ventriculomegaly. Then transthalamic plane, that is, we can take the biometry in this plane. We can take also biometry can also be taken in the transventricular plane. Then come to the transcerebellar plane. We look at the transcerebellar diameter. We look at the cerebellum. We look at the cerebellar vermis. So you can detect a posterior fossa cyst, the megacisterna magna, cystic hygroma, scalp edema. So what are the key points? The head is imaged in 3 planes: the transventricular plane, transthalamic plane, transcerebellar planes. It's important to identify the specific landmarks. Any variation in the appearances should raise a suspicion of the anomaly. The lateral ventricle more than 10 millimeters, cisterna magna more than 10 millimeters, refer. If the head circumference is less than 5th centile or more than 95th centile, to refer. If the TCD is less than 5th centile or it's altered shape, then we need to refer. Thank you.
Thank you
so very much, Suchita.
Yes,
shall we, I think you ask the questions, or should
I think let Ashok Khurana sir give his comments.
Yes.
Ashok sir.
Yeah. Thank you, Dr. Suchita. That was a beautifully put talk for us. You took us simply through all the earlier part of pregnancy, just the way I would like to learn, and simplified it. I think it was also very useful to understand normal by showing the abnormal, and that worked out wonderfully. What has also been emphasized very correctly is the fact that it is possible at the 11 to 14 weeks window to diagnose a large number of abnormalities, particularly neural tube defects, which are so common even today in our part of the world. You've also learned that a systematic evaluation will be able to diagnose most abnormalities, and that there would be a need for referral only for a very small number of cases. And then you have learned the planes. These have been taught to you before, but we have learned today and re-emphasized the need that we have landmarks for every plane, that we must follow those landmarks. We look at each component of each one of the planes, and we take the basic measurements, which should be taken in exactly the way that she has shown us. We've also learned an excellent referral pattern, where if we find a head circumference less than the 5th centile or greater than the 95th centile, that we're supposed to refer, or in case you feel you have the expertise, first see yourself and then refer. And also if you have a small transverse diameter of the cerebellum, that you need to handle that as well with a referral. You've also learned that absolute measurements may not always be what is important, but you need to work out the centile. And therefore you learn to see on your own machine, where are the centiles actually located. You will realize that for every single one of these measurements, your machine actually gives you a centile. And if it doesn't give you a centile, all you have to do is to call in the applications expert, and they will make sure that when the figure is shown on your screen, the centile will also be shown on your screen. You've also learned with confidence that if we do go through the so-called plane 4, 5, and 6, then you will be able to diagnose almost all those abnormalities, and systematic evaluation of these planes will make sure that you diagnose over 99% of abnormalities, because they're usually very gross. So that is the great advantage that we have seen today. What we will continue to learn over the years is that, yes, there are a few abnormalities for which we have to work harder, and for which we have to go in and do a neurosonogram, and that includes other disorders such as those of the posterior cranial fossa, etc., or when we're looking at agencies of the corpus callosum, or we're looking for some variants of holoprosencephaly that don't fit in instantly. Sometimes you might need to tell the difference between ventriculomegaly and holoprosencephaly. And if you follow the algorithm that she has shown, there is no way that you could miss this. The first thing that Dr. Hasmukh emphasized for us was that we must be able to identify that this ultrasound scan is normal. If you've done that, that is fantastic. And if it is abnormal, then it needs a referral onto an appropriate center where this can be evaluated. So remember that we will continue to work with basic planes, basic protocols, basic measurements, and say, okay, normal. If we find any variation, then we need to refer to a center where this can be handled. And therefore, we will be able to then see things very, very nicely. The important thing to also remember is that there are a lot of normal variations, and one which is being discussed in the chat box at the moment are things like a Blake's pouch cyst. We know that there is an embryology, and embryology is extremely important to understand. So to try and say that the cerebellum does not look good at 14 or 15 weeks may not be very wise, because there's a good chance that it just hasn't started forming yet. And therefore, it's a wise idea to actually do these scans at the right time. Until we got the new MTP law last year, we had a deadline of 20 weeks. And very often the corpus callosum used to not be complete by that time, because we know that it takes up to 20 weeks to complete. So when we were trying to do scans at 18 and 19 weeks, we used to miss a lot. Now we know that the new MTP law allows intervention, that means termination of pregnancy for lethal abnormalities or abnormalities associated with poor quality of life, all the way up to 24 weeks. And therefore, we should time our scans to later in pregnancy. So the anomaly scan should now be done between 20 and 22 weeks, because we still will have 2 or 3 weeks left for our genetic workup if necessary. Also remember that when it comes to abnormalities, and there are a lot of abnormalities of the central nervous system that will be manifested late, such as ventriculomegaly secondary to infection, or not so, neural tube defects, which are very, very subtle. And the fetus and the parents no longer have to be going through the whole pregnancy and giving birth to an abnormal child. The new law says that if you go to a medical board, which has been appointed, and this is now available in most government hospitals, and in states where this is not available, it will be done within the next 3 months. Then with the permission of the medical board, a termination of pregnancy after making the fetal heart asystolic with potassium chloride can be carried out, provided the medical board gives permission. The medical board will consist of people who are psychologically sensitive. It will consist of experts, and they've already been appointed in most hospitals, like I said. So we must understand that embryology has to be respected. The Blake's pouch cyst, for instance, is something where we understand that the fenestration, or the opening of the fourth ventricle and its communication with the Cisterna Magna can be altered and still be a completely normal variation, that initially there is outpouching through the midline, and that is a normal variation called the Blake's pouch. If it persists beyond 22 to 24 weeks, we call it a Blake's pouch cyst. If it is associated with an abnormal cerebellum, we will call it verminogenesis. And if there is a huge big cystic mass, with an upward rotation of the tentorium and the cerebellum, that becomes Dandy Walker. So these definitions are well known, but they are to be applied at the right time of pregnancy, and the prognosis is different. And if you follow what you've just heard, there is no way that you're going to miss these. So please treasure this as an excellent talk that we have heard, and go step by step and make sure that we make the right diagnosis. First step, is this normal? Second step, is something gray zone or abnormal? I need to refer. 2 simple steps. Thank you, Dr. Suchita, for a very good talk.
Thank you.
Thank you very much, Professor Khurana. Wonderful elucidation and resume of Suchita's lecture. And at the outset, I would just ask you a question. Does HS40 Samsung have these
Centiles?
Centiles?
Yes, it does. So you can program this to appear on the screen by going into the system utilities and switching it on.
So that has to be seen. The machine that they brought on the 16th and 17th,
Yes.
I missed out this particular part, whether they had it or not. That's why.
Yeah.
Anyway, it's very important for those who have been supplied with this HS Samsung. I know that GE has it. So
Otherwise, the application specialist can actually do it. Actually, if we give them a chart, the applications specialist, they can put it in the machine, I believe. Yeah.
Yes, absolutely right. That the standard charts available on the internet and in all textbooks, and the applications expert puts in that data. It takes them no more than 45 minutes to finish this whole chart, and it automatically gets programmed.
Even the vascular indices also have their charts. The pulsatile index and
yes,
flow.
Absolutely. All the Doppler indices of all the major vessels that we use for our growth restriction evaluation, as well as for preeclampsia prediction, have the centiles all put in.
Yes. Shall we go for the questions Suchita has prepared? One by one, Suchita, please ask. And if nobody can answer, Professor Khurana and Dr. Hashmuklal can discuss the answers. So go to your questions.
Ma'am, Suchita ma'am can read the questions and we will wait for 2 to 3 minutes for response from the participants in chat box.
Suchita can do one thing, because she has it on her laptop. Why don't you? Suchita, you can actually show those questions by your sharing screen. You can show it.
Yeah, share the one which does not have the answer.
yes, ma'am. I've taken out.
So I had given two sets. No, the one which without the answer, you share that one. And
yes.
As Sambit said, the participants can post it in the chat box. The answers.
Madam, can I come in?
Yes, Ajit.
Madam, good afternoon. Madam, we got a case of ventriculomegaly.
Yes.
Then we have done further scanning. We found banana-shaped cerebellum and obliteration of the Cisterna Magna. Then we scanned the spine. We got in the sacral area, we got meningomyelocele.
Yeah.
So ultimately, it came to be unrolled cherry malformation, madam.
Yeah, it is possible. It is possible. Yes.
So what is the prognosis?
That I want to ask from Khurana sir or Hashmuklal sir, what to do?
It's a severe abnormality.
What is the week of gestation?
The outcome is very poor, actually.
Yes.
Ashok sir, let Ashok sir say.
Yes. So this is the natural sequence of events, and Arnold-Chiari malformation type 2 is actually a natural consequence of an open neural tube defect. And this means that there is a herniation, as we have heard from Suchita, a herniation of the posterior fossa contents through the foramen magnum, and therefore it results in the classical Arnold-Chiari malformation and the ventriculomegaly. In general, if you have a high neural tube defect, located in the neck or in the thorax, that has a very, very, very poor prognosis. The ones that are in the lumbar and the dorsal-lumbar area have a poor prognosis, but they have a reasonable quality of life, but we will lose them to kidney infections, etc., in their third or the fourth decade. And the sacral ones can be quite variable. They can be completely normal for a few years and later on go on to ventriculomegaly, club feet, disorders of being able to move their limbs, and ultimately loss of bladder and bowel control. As we've heard from Dr. Hasmukh, this is a uniformly poor prognosis, and therefore the patients must be made to be aware of that. Before we do that, we should also make sure that we counsel them about continuing their folic acid throughout until they have completed their pregnancy, and not to stop a single day. Also to look for other associated abnormalities, which will tell me whether this is a syndromic neural tube defect or it is an isolated neural tube defect, because in that case, I would need to have genetic evaluation. So such cases should be sent to a specialist in fetal medicine so that a complete workup can be done. But it's a very, very good finding that you made, because the patient then had the options. If it was less than 24 weeks of pregnancy, they could really walk into any hospital, and if two obstetricians sign consent, they will be able to terminate that pregnancy because it has a uniformly poor prognosis. On the other hand, if it is more than 24 weeks, then they will have to walk into a hospital which has a medical board, and the patient does not need to go to the court for this, and the medical board will give permission for this particular procedure.
Thank you, sir. Thank you so much. Yeah.
My pleasure indeed.
So, Suchita, you are going to read it?
Yes, sir. Yes, sir.
Make a slideshow, full screen.
Go to full screen, Suchita. Yeah.
Yes. That's good.
Number one question. Absence of cranial vault is known as, straightforward question. Absence of cranial vault is known as encephalocele. Encephalocele. Then question number two. Following are true about ventriculomegaly.
Those who want to give the answer, please give it in the chat box so that Sambit can, make a percentage of knowledge gain. So all of you, please, those who all of you who have heard this question, please give your answers in the chat box, so that from the majority who are attending, what is the percentage who have answered correctly? You can, because 1B, yes. Then we'll go to the next question.
Yes, ma'am. Following are true about ventriculomegaly. The lateral ventricle should be more than 10 millimeter. It can be an evolving abnormality. Chromosomal abnormality and infections are the common causes of ventriculomegaly, or all the above?
All the above. All the above.
Correct. Absolutely correct.
So the correct answer is D.
D.
All the above.
All of the above is the correct answer. D is the correct answer.
D is the correct answer.
Okay, let the participants put it in the chat box. We won't discuss. Okay. Next question.
All the following are true about the atria of lateral ventricles, except it is measured at the level of glomus of choroid plexus opposite the parieto-occipital sulcus. The calipers are placed at the inner edges of the ventricular wall. The calipers are aligned perpendicular to the long axis of the ventricle. Then calipers are placed at the outer edges of the ventricular wall. So all the following are true except
D.
Except
one which is not right. Please,
all
please,
of them are
please
correct
attend one which is
one.
not right. Yeah.
Okay. Shall we take the next question?
Lemon sign in a banana-shaped cerebellum is seen in holoprosencephaly, open spina bifida, anencephaly, or genesis of corpus callosum. Lemon sign in banana-shaped cerebellum.
Question 4, chat box.
Open spina bifida.
Yes, correct.
Yes.
Open spina bifida.
Next question.
The following are true about...
Everybody, you should know why there's open spina bifida, why there's banana sign, which Dr. Suchita and Professor Purana have explained.
I think we will talk about it afterwards. I can
we'll
analyze
discuss.
that. Yes,
We'll discuss.
I will analyze that.
Dr. Hasmuklal will discuss all the questions. Okay.
The
Question
following
5.
are true. The following are true about holoprosencephaly.
Question 5.
Yes, ma'am. The following are true about holoprosencephaly. The midline farx is not visualized. Loba, semiloba, loba are the 3 types. Associated anomalies are seen. All the above.
All of the above.
All of them. Correct.
And 6. Question 6.
Holoprosencephaly most commonly occurs in trisomy 21, 18, 13, none of the above.
13.
13.
Trisomy 21.
Okay, question number 7.
Teardrop shape of the ventricle, that is colpocephaly, is seen in anencephaly, holoprosencephaly, agenesis of corpus callosum, encephalocele.
Genesis of corpus callosum.
Agenesis of corpus callosum. Correct.
More than 15.
The next question. Mega Cisterna Magna refers to Cisterna Magna of size less than 10 millimeter, more than 10 millimeter, more than 15,
More than 10.
more than 10 millimeter.
15.
Correct.
110.
I think this question, Suchita, more than 15 also is correct.
Yes, yes, ma'am. Yes, yes.
That is why I always want to
Yes, yes,
take
ma'am.
questions. So you should not confuse, because somebody if
Yes, yes, ma'am.
3 also will be correct, no?
Yes, ma'am. Actually, I missed it out.
MCQ training also is bad. So,
Yes.
so that you should not be ambiguous. Okay.
Madam, namaste.
Yes, ma'am.
Namaskar, Saroj sir. तो सर एटिके रही थांतु प्रोसेस पर्यंत आमे गोटे डिस्कस करथुलु एनीमिया प्रिवेंशन केमती गोटे आउट ऑफ द बॉक्स केमती भाबी की गोटे पूरा फुल स्टेट वाइड गोटे केमती गोटे काम करबा.
I would request participants not to leave now because we have something very important things to discuss also. Participants don't leave. Even if you are not attempting the question, just listen to it. But stay there because we have some messages for you now after this. Yeah.
Next questions. Next question.
The following is not true about transcerebellar diameter. TCD corresponds to the gestational age up to 20 weeks. Cerebellum refers to two dumbbell-shaped structure connected by echogenic vermis. TCD is measured from inner edge of the cerebellum to inner edge. A normal range of Cisterna Magna is 2 to 10 millimeter. The following is not true.
Answer is C.
Yeah, it should be measured from outer edge to outer edge of the cerebellum. Outer to outer.
Question 10.
Absence of skull integrity is seen in ventriculomegaly, encephalocele, agenesis of corpus callosum, dandy walker malformation.
Encephalocele.
Encephalocele.
Yes. Encephalocele.
Correct. So, Sambit, have you been able to work up the percentage of?
Madam, as there was no pre-orientation polls, so we can compare.
Okay, just don't compare, but I think participants be there because we will share some
Most
important.
have answered correctly. There was some
yes, ma'am. Post-orientation chat box responses are mostly everyone has responded correctly.
Yes. So I think we get back to question number 1 and let Hashmukh sir as well as Professor Khurana discuss regarding those questions.
Right. So absence of cranial fault is known as, out of these 4, the anencephaly is the correct answer, as we know that what happens in the cranial vault is missing and therefore initially the brain is floating and subsequently the amniotic fluid erodes the brain tissue and the whole shape of the head is completely becomes flat, or it is as if there is no we can't measure BPD with these fetuses, and the entire brain is almost missing because of the amniotic fluid has almost eroded the brain. So it is a acrania anencephaly sequence. That is why it is called. Ashok sir, you will also comment on this whenever you can add something.
Different varieties of anencephaly.
Yeah.
Professor Khurana, please.
Yes, this is exactly as Dr. Hashmukh has told us, that some of them, of course, are completely anencephalic from the beginning, but it could also be that initially there was just the acrania, and then that progressed to wearing off of the brain, which we now call exencephaly, and finally it goes on to anencephaly. So that is the process, and in both these conditions, essentially, the cranial vault is just not there. And as we have heard from Dr. Hashmukh, the amniotic fluid wears off the entire brain, so that ultimately, usually when we get to see these patients at the time of the anomaly scan at 20 weeks, we don't see any brain tissue at all.
Thank you, sir. Thank you. Following are true. Yeah. Should I go for the second one? Yeah. Yes. Following are true about ventriculomegaly. The lateral ventricle is more than 10, can be an evolving abnormality, chromosomal abnormal, and I think the right answer is all of the above. And it is very, very important that we do not miss ventriculomegaly, because in 1%, the incidence is almost 1%, and the implications are great if it is in evolving dilatation. And I think this has an entire one lecture in our SFM lecture webinar. So it's a very large topic.
There's a variety. There's a variety.
Yeah, there's a variety. Anything.
Just marginal increase in the ventricles. That is another variety where outcome is not so bad. I would like Professor Khurana to talk about that, because some of them may find just mild,
moderate, and severe. Sir, please tell about mild,
and
moderate,
the
and severe.
outcome of what should be our approach to mild ventriculomegaly.
Yes, you see, because some ventriculomegaly can be a normal variation, and because some ventriculomegalies can have a very poor prognosis, for many years we've been trying to quantify ventriculomegaly and find out which one is associated with the poor prognosis. So the ones where any of the ventricles is more than 15 millimeters is referred to as severe ventriculomegaly, and that is definitely abnormal. Then we have the group that is between 10 and 15. And in some classifications, we call them mild. And in some classifications, we divide them into mild and moderate. So 10 to 12 would be mild and 12 to 15 would be moderate. Interestingly, it doesn't really matter whether it is 11, 12, 13 or 14, because in all of these, the prognosis is variable and depends on the workup of that ventriculomegaly. So the ones that are straightforward cutoff are 15 and more. The ones that are normal are 9.9 and less. But between the rest of them, 10.1 to 14.9, we need to investigate them very carefully, because they could go in the normal way with a good prognosis, or they could go with absolutely prognosis.
Hello?
Or a live
I think Professor Khurana has got disconnected.
I think, yeah, sir, it's not audible. Anyhow, it is. See, the greater is the ventriculomegaly, the greater is the poor outcome. And almost anything above 50 has an obstructive cause. And it is some very, very common that these fetuses will have aqueductal stenosis. And also that anything obstructive. See, infection also is one of the very, very common cause of ventriculomegaly, and it has to be ruled out. Genetic causes, infections, chromosomal. So it involves a lot of workup. And these are, see, the most difficult ones are that unless if somebody has not taken the measurement of the ventricle in a very, very proper plane, then these borderline cases, like something which we call 10, because 10 we call abnormal. 10 is a dilated. 1 to 9 we say normal, and 10 to 12 comes under mild ventriculomegaly. So the measurement is very, very important, and head has to be in an axial plane. The image has to be magnified appropriately so that the head shape is major, or I mean 2/3 of the image of the screen. Focal zone is very important. Cerebral ventricles should be symmetric in appearance. Midline fox should be in the middle. Atrium and occipital horn of lateral ventricles should be clearly imaged. And calipers are placed on the just inner to inner. I think, and the place is Dr. Suchita had already shown us the parieto-occipital sulcus and the glomus. So both are actually very, very close. So because glomus sometimes can be misleading, so this parieto-occipital sulcus is the important landmark where we measure it actually.
And therefore PPTs will be supplied to all of you, and please go through that over and over again, so that when you actually scan, you will be able to be guided properly. And what are they supposed to, even if they detect a mild ventriculomegaly, should they not refer?
It should be followed up also.
Yeah.
Yes, they should follow up, but they should, I think, inform the radiologist or the fetal medicine expert. I think as a corollary of this entire program, we should have a proposal. I think Saroj Panigrai will help us. Samvit, I think you will agree with me that we can divide the fetal medicine units, even private units. We can have a private public partnership with the government, and some kind of referral centers should be identified, so that the fetus, the patient does not have to be penalized, and quickly she can get an answer to her problems. So since we are looking at normality and looking at what is not normal, so when we know what is not normal, we should have a clear-cut directive as to where to send this patient. Maybe the radiologist will be very busy with other different types of ultrasounds that they are for obstetric ultrasound. I think we should have identified fetal medicine centers to refer to. So this was what I was always thinking, that whenever any of the specialists find something abnormal, what are they supposed to do? This is something I think you would agree with me. It's vital for patient care and for outcome. What do you say?
Yes, I fully agree there that a referral pattern should be in place. And once we've identified an abnormality, it then becomes within the realm of the fetal medicine specialist to guide further treatment. There are a lot of radiologists who are very good at fetal medicine, and a lot of obstetricians who have specialized in fetal medicine. And we should know which direction any one of these can be used. Because here, for instance, ventriculomegaly is the most classic example, where you could have a mild ventriculomegaly and yet have a completely normal outcome. So we do not want to destroy healthy fetuses, and we want to give each fetus an optimal outcome, which means that yes, mild ventriculomegaly, MRI normal, infection screen normal, genetic amniocentesis normal after doing a microarray. Therefore, prognosis likely to be excellent and likely to be good in over 90 to 95% of cases. Whereas on the other side, if MRI shows that no, there is a mass sitting at the level of the aqueduct, poor prognosis, and therefore the option should then be given to the patient on whether they would like to terminate or not, depending on their personal or religious beliefs. So to guide this entire thing, we need a referral service. And but the important thing, of course, is the first step, identify ventriculomegaly and then guide further. So if we could create a referral system, that would be ideal. Also, you must tell the patient that, look, I have a finding, but that does not mean that your baby will be abnormal. We need to evaluate this further and decide, is this baby going to be normal? And if it is going to be abnormal, is it mild or is it severe? And is it going to be something which with only a minimal compromise of quality of life? And that is something we have to sensitize our patients to, that, look, we're not in the business of guaranteeing babies. Anybody can have any disease at any time.
Again, sir has got disconnected, but we had him at the right time. So next question. Next question. Oh, again he's back. Thank you. You're keeping in and out disconnect. But you joined us at the right time. To give the right advice.
Okay.
So we'll discuss the third question.
The fourth one is the lemon sign and banana-shaped cerebellum is seen in. So right answer is the open spina bifida, as Suchita had already explained this, that the CSF is leaked. It goes all downwards, and therefore it pulls the brain backwards, and the cerebellum becomes compressed, and the frontal bossing, the frontal bones are collapsing. I think this was very important, I mean, historical aspect, which Ashok sir and me, we are familiar because we heard it directly from Kypros. You know, this particular sign, I think Kypros said he said he accidentally discovered this lemon and banana in 1980. And
Yes.
should I tell a little bit for a minute?
I
So
think
open
so.
spina bifida,
Yeah.
this lemon and banana was discovered by him. And in 2009, this IT was discovered by Rabi Shavi, a friend of Ashok Khurana sir. Ravi was recently in Jodhpur, and I think in the SFM group, I have narrated all the papers which Ravi has done so far, an elaborate work. And he also received in Singapore the Stuart Campbell Award. So 2009 again, in first trimester, open spina bifida could be detected by IT was the discovery of Rabi Shavi. And one more thing, I think Kypros was very firm, and he was very a great critic of Americans, because what happened is they were not taking this as a lemon and banana as ultrasound markers in the beginning. They were still carrying on with the alpha fetoprotein. And he said they have wasted 31 years to accept that ultrasound is the best marker to detect open spina bifida by looking at lemon and banana. So also I have an important thing that for all our colleagues who are obstetricians, don't waste your years. Ultrasound is your great tool. Learn it. You must. It is a very fascinating tool. Don't ignore ultrasound. If you are ignoring today, you will waste your time. I mean, this is a very, it has a great
you will
diagnostic
be laggards on the way.
Yeah.
You will be laggards on the way.
Yes.
So I think that is, Ashok sir, if you have anything to say, please go on.
No, this is so perfect. I think we must realize this, that findings of research today must be rapidly translated into clinical use. Otherwise, it is of no advantage. 31 wasted years and the number of crippled children is something that is tragic. These children are bedridden. They have a problem even with their minds because they go in for so much of hydrocephalus. And then they have a very poor quality of life. And that means tragedy for everyone around them. And if it wasn't for the tragedy of their own lives, you would say, okay, the family should put up with it. But when their own quality of life, their own cognition, etc., is so poor, we must rapidly translate and say, look, we have a marker here. We should use it. We should train our mind to say, okay, this is not ovoid. This has a bump in the front, and I don't see the wonderful kind of cerebellum that Suchita has shown us today, and therefore I must refer further. So we really must have this, and I'm so glad Dr. Hasmukh has brought this up, that we should not waste years, and every obstetrician must learn to do at least basic ultrasound and preferably move on very rapidly to advanced ultrasound.
Sir, Kypros, you know what he said? He said, how can you be good doctors if you are not, if you are blind to the subject you are treating? If you are not
True.
looking at the fetus, you are blind to it. So he said, how can you become a good doctor unless you are looking the fetus directly with ultrasound? A great advocate. No?
Yes.
So,
next question.
Suchita, number 5. The following are true about number 5 is the right answers are all of the above, because holoprosencephaly is a very severe kind of defect, and this is we can identify right in first trimester. And all these things are, we can associated anomalies, because it is very true that it is a trisomy 13, and these things are very easily detectable because we will see multiple defects in trisomy 18 and trisomy 13. It is only the trisomy 21 which will be hidden. You know, we sometimes we may not find anything, and these children, they live for a long time. And you know what was this is another point I let me tell you, that Kipros was concerned. He said, oh, when I was walking in the streets of London, I saw a lot of Down's children. So he said, I must do something about them. So something I should be able to diagnose right before they are born. So this is how I think he was very inspired with fetal medicine. And all of the above in this number 5 questions are right. About holoprosencephaly. Yeah.
6.
Sir, anything you want to say about this?
No, this is excellent. It's a beautiful overview.
Yeah. So number 6, I have already told that the answer was trisomy 13. 13. Now number 7 is again very interesting. This teardrop shaped of ventricle, it is known as colpocephaly, is seen in. It is seen in agenesis of corpus callosum. Because why it is like that? Because both the actually the commissure, I mean the corpus callosum unites both the lobes of the brain. Now once it is not there, the brain falls apart and it compresses the anterior horn. So anterior horn will collapse and the most of the fluid will accumulate in the posterior part. And that's why it becomes a tear-shaped ventricle. So teardrop shaped, it looks tear, and this is the finding of, and I told you it is because why it happens in agenesis of corpus callosum. Anything, sir? Ashok, sir?
Yes, absolutely. So you see this sensitivity of a sign like a teardrop shape tells us that when we look at ventricles, we should look not only at the size, but at the shape. And we know that we get to then see agenesis of the corpus callosum. And the importance here is that we don't want to miss this sign. It is tricky to see the corpus callosum. It can be directly visualized only in a mid-sagittal view, which is not a routine view when we do our anomaly scans. And therefore the indirect views, so to look for teardrop shape and then to go on to look for the fox, etc., becomes extremely important. And then to refer that, yes, I don't see things correctly. And so therefore, the answer, of course, is agenesis of corpus callosum, and it's important to look at the morphology.
Yeah. Thank you, sir. Number 8 is a very direct answer is there, that anything above 10 millimeter, because 10 is the limit, anything above we classify as mega cisterna magna. Ashok, sir?
The outcome of mega cisterna magna. Professor Khurana? Sir has got disconnected.
Again we will have to evaluate the fetus in by neurosonography, and we have to find everything. Sir, Ashok sir, please say about outcome of mega cisterna magna.
And would these have to be referred to find the mega cisterna magna?
Yeah, until recently, we used to believe that mega cisterna magna is an innocuous finding and is not associated with any associated abnormalities. However, in the last 2 years, we've had several papers indicating that a simple measurement without looking at morphology may not be enough. And therefore, when we do spot something like this, it becomes important to refer again for a fetal medicine consultation. because it could very well be a problem. So the moment we find anything more than 10, we don't presume it is normal, or we don't presume that it has a very good prognosis always. We don't want to miss any child who will have a compromised quality of life, and to give the patient the option on what they would like to do.
Thank you, sir. Thank you. Is it, can it be with, there are a lot of
everybody
other problems
is
like
following Professor Khurana and Dr. Ashmukla. These discussions are extremely important.
number 9, following is not true about the transcerebellar diameter. The exception is we don't measure it. We measure from outer to outer, and therefore C is the correct answer. TCD measured from inner to inner will be incorrect. So C is the wrong answer, and that is the exception.
I have a doubt here. We were taught by Dr. Suresh that TCD corresponds to gestational age up to 28 weeks.
Up to 26. Up to 26.
Here it is mentioned 20. ISWAG says 20.
Yes, ISWAG is 20, and in our Indian babies, we would manage it almost all the way up to 24 now. 24. But because you see, the machines have started showing us much more than they used to show earlier when these statistics were made. So because our machines see much more,
so
we use it as a rough index. But the point is that we don't use it to date a pregnancy until much later in pregnancy.
Exactly.
And therefore, we must use the centile chart. And this is the advantage of having the centiles on. And we've learned that lesson already in our talk today from Dr. Suchita, that let us use centile charts and move away from the old information about normal range being connected to gestational age roughly. We cannot afford to be rough anymore. We have a better tool, so we should embrace the better tool.
So instead of taking that rule, that TCD corresponds in millimeters.
Yes. We would use it as a rough guide.
We should not depend on that, but on centiles.
Yes, absolutely.
So this is the message. Hope everybody is listening. Next question.
Yeah. So the last question is, absence of skull integrity is seen in. The right answer is Encephalocele. I think this is Dr. Suchita had already mentioned that sometimes it is very small and can be missed. Otherwise, and it could be anterior, it could be lateral, it could be posterior. So the location, again, I think we discussed this in our earlier lectures also about Encephalocele. So Encephalocele is the right answer.
Recently, I missed one at 13 weeks plus scan and found it at 20 weeks, and I had shown the image to Professor Khurana. It was in the occipital region, the encephalocele.
Yeah.
And the poor fetus was nicely moving about and active, and the mother was feeling nice. But it's a huge disappointment to the parents to see that this baby, which they conceived with such difficulty, has to be terminated.
Yes. But these evolve also. We always say that even after we do the 11 to 14 week scan, it does not replace the and then encephalocele can be quite not visible earlier on, and therefore very important for us to realize that we must always follow it up. You don't pick up 100% of encephaloceles because they might be very, very small at 12 weeks, and they can be fairly large later on. I think that completes our questions for today.
Yeah, I think that. And I think for all our participants here, let me tell you that when we have on-site training, we will each one of us, I mean all the trainers, they will precisely tell you about how to magnify, where how much magnification is required, how to measure inner to outer, and all these concepts, and how your focal zone has to be. This will be on the spot, right, when on the machine itself before you, and at that time you could ask any more questions directly to all our trainers when we are, and that's, I believe that's going to be very, very soon. And the whole program is almost done by our UNICEF team. And at that time, again, I think before that, we would love to meet Ashok Khurana sir in Bhubaneswar once again. So we had a great time last time. I mean, we learned a lot from you. So the simulator was very great.
Yes, that was a very good exercise. It was a pleasure indeed. So I should look forward, and I look forward to many Fridays before that.
With your effort, we could retain it for one more extra day. That was an advantage also.
Yes, thank you.
Right. So
thank you very much. So,
thank you indeed. Yes.
Regarding working out in detail the on-site mentoring,
sir, can I let me talk something more, sir, because you and Shyama madam both are present here. I was recently in when I went to Bhilai this time. That was our SFM chapter meet there. You know about it, and you were also talking about the Doppler and the growth.
Yes.
So I asked the HOD of Medical College in Raipur. Nobody is actually teaching gynecologists the basic steps. I mean, I asked Jyoti Jaiswal that who teaches ultrasound. Then she said, we send our students to radiology department. They just observe and come back. So I think Shyama madam is with us today. I would firmly request you to see that every gynecologist in the OZ department, right, we catch the young people, the young gynecologists, and we teach them from the basic to the advanced thing. At least 6 months or 1 year, or at least 1 year, entire 1 year duration, they must work in the ultrasound department directly. In the labor room also, because ultrasound has a lot to do about labor, and I believe if it is used in labor room properly, many CS will be avoided. Do you agree with me, Ashok sir?
Yes, I think it needs to be used everywhere, really, in the labor room, in the ward, as well as in the OPD, in the outpatient section. And we should add up not just the number of months or years, but the number of hours spent, and people can clock in the number of hours and make sure that they've completed at least that much with at least 50% under supervision, so that we make sure that this inexpensive technology is put to great use, because in the long run, we really have a very, very excellent ultrasound-based diagnosis and prognosis.
Yes,
and I think
because in the last TOT, the inputs given by most of the trainers was that the unused ultrasounds which are there in most of the FRUs and headquarters should be brought to the labor room. So this should be another proposal which the government should allow, and the PCP and DT people have to give the permission. Because there are, I think, the participants in do you have an extra ultrasound apart from the scan room in your place? If you have, I think
madam, we have in Paripada.
Yes, you also gave a suggestion that it should be used in the labor room. And many, so like you did.
PCP law is very straightforward.
It's a very important and pardon?
The PCP law is very straightforward. It is just misinterpreted in some districts by the appropriate authorities. But in most districts, it's very clear that permission is given to be able to move the same ultrasound machine when the outpatient section is not on, it can be moved into the ward. And that is just by information. So we must guide our PCP entity authorities, work together with them and explain to them that yes, this is not being moved out of the building because the law clearly says it can be used within the building.
And moreover, we are dealing with the patients in labor where
Yes.
it doesn't matter what
Yes.
whether we detect the sex or we don't.
Yeah,
It's the life of the fetus that matters, life of the mother and the fetus.
Yeah.
So I think our government is quite sensitive, and our department, DFW and MDNHM, they are very much they understand this issue, and I think they can put their foot down so that the PCP&DD people do not make a lot of noise.
True. Because all it needs is a letter saying that, yes, we would like to move this.
We will have a definite proposal, and we would like your recommendations also in that proposal, so that we'll say that you have recommended. And you also can take it up with the government of India or other states.
Yeah. Well, you know, we've had a clarification from many states. And so that's not a difficult matter at all.
So I think it's a very important thing, and it should not, the name of it is now. If we don't move the machine now to the labor room, today itself some fetus will die, or
a mother will die.
Decision, a mother will die.
Yes.
So I think your participants, I hope you have understood this last part, very important part of the discussion. If you have a machine of your own, please let the DMRCH or your district DPM or your BPM know about it, and contact contact Mr. Saroj Panigrahi. He is very dynamic in helping us take this program forward. So this is an important, very important issue. We must have, if we have an extra machine, we must put it in the labor room. Or as Professor Khurana said, the one which you are using for your scan, you can move it into the labor room when it's not in use.
The best is that ultrasound room should be adjacent to the labor room. I think in Titlagarh Hospital, the machine is very much in the next, very adjacent room to the labor room in Titlagarh. Yeah.
At SCB also we have quite close, but then there are walls.
Yeah.
And we have some extra machines. It should be functional in the labor room itself. Ajit, what do you say? Hello, Ajit. Have you left? I think all the postgraduates are allowed to attend this training program right from after one or two sessions. The MKCG people requested, and the government has allowed them to, in fact, welcome them to attend these training sessions.
Ashok sir and Syama madam should prepare a good curriculum for our education, you know. And I think Ashok sir could take it to the national level everywhere.
We've tried the national level. The national level says it's not our subject. But we will gradually bring them around. It might take me another year or so.
At least the education part, I think, to the postgraduates, who are
actually it should start from the SFM members and Oxy members. It should start by their initiative. Those people who are in the government, like we started here in Odisha. It was we who gave the proposal. It's not the government. The government did not think about it or did not know that it could happen like this. So I think if our Foxy members are sensitized and they start this kind of program, it will be good. Because something of the kind did happen in Tamil Nadu by Dr. Suresh.
That's right. He had actually trained non-obstetricians, primary care physicians, to spot at least 6 problems. And it worked very well. And that's why all my eyes are on Odisha at the moment. The moment we have this as a successful program, I promise you we will use this with full credit to everybody involved in this program to a national level.
But the name is today, so instead of waiting, sir, I think you as a SFM founder, you should put your foot down and ask all the other states to start the program straight away.
Yes,
Is there NHM district, states NHM who give proposals as we did?
Yes, but I need a Shama Kanongo and an Hasmukh Lal in every state.
You would need a Shalini Pandit also. It's because of her. She's very, very positive and she's very happy with the program. So,
Yes.
So you need Shalini Pandits also.
Yes, absolutely. But we will push this. You're absolutely correct. I'm so glad you have inspired me. Yeah. Thank you so much for today. This is a really pleasure.
Thank you very, very much.
Yes.
So next will be on by Rama Manjari on face and lips, I think.
Yes. Coming Friday. Yes.
Coming Friday.
Thank you, sir. Thank you so much.
Thank you very much.
Nice meeting you.
Thank all the participants. Hope you had a very good day of learning. Enjoyed all the learning. And
Ashok sir, this what happens, I feel sleepy at this hour because after lunch, at 3 o'clock, this is
I'm very comfortable at this time.
and actually what happens is I take pakhal, so it makes me sleepy actually.
Yes. All the best. Thank you.
You, sir.
Thank you. Odia's staple food is pokhalo.
I know. I like it too. Thank you.
Thank you very much.
Sambit,
shall we call? Sambit, of course, you're sharing today's PPT with all. Baske sir, Nihar Misra, hope you enjoyed. Suchita, thank you very, very much for your excellent presentation. A big clap to you.
My pleasure, ma'am.
Made things very, very